Hello, everyone. I'm Tony York, and I'm really happy to be with you today and looking forward to chatting with you about some really important principles about the built environment inside of healthcare and how we can create a safe hospital design. A little bit about me, I just wanted to share with you. I've had a chance to do a little bit of writing in the industry, the hospital and healthcare security, the industry textbook. I have been very fortunate to be the author of that. But in addition, I'm very involved with the IAHSS, the International Association for Healthcare Security and Safety. And not only have I served in their board of directors and as their president, but I'm a very active member of their Council on Guidelines, which creates the industry guidelines for healthcare security, as well as the task force that created the security design guidelines for healthcare facilities. I'm currently Executive Vice President for the Paladin Security Group. We are an organization based out of Vancouver, Canada, with a U.S. subsidiary called Pal American Security. We do a tremendous amount of hospitals. We work with well north of 350 organizations that service the healthcare entities. And we're excited to continue to be very innovative and think about all the different ways that we can keep healthcare safe with staffing, with technology, with just smart thinking towards how do we create a safest environment we possibly can at the smartest price point we possibly can do it at. So a little bit about today. I was hoping to give you all an understanding about the big picture of violence inside of healthcare. And then what do we need to do to design a safe organization? And then I've got some very specific slides I want to just share with you, walk you through about the emergency department, and then actually a standard patient room and some of the implications of ligature risks inside of those rooms. And then we'll see what we can do for your question and answers throughout the chat. Well, let's start here. Let's talk about what's going on inside of industry as a whole. When we start thinking about all workplace injuries, healthcare represents about 20%, pretty consistent with what it represents as part of the GDP. But when you start looking at the amount of assaults that happen inside of healthcare, what you're finding is that healthcare actually is over half. 50% of all assaults that happen inside of all of industry happen inside the healthcare space. So let's dig into a couple of these things just a little bit more. I mean, some of you may not be as familiar with this phenomenon of violence in healthcare, but the bottom line is violence in healthcare continues to be on the rise across the country, frankly, globally. I've had the opportunity to meet healthcare leaders from a number of countries throughout the US, Canada, as well as those in Europe, Australia, and Asia, and they're all facing similar challenges. The reality is that hospital staff, nurses, and doctors in particular are victims of violence on a daily basis. I've been involved with running operations for hundreds of hospitals with healthcare facilities, and it's taught me one really sad truth, and that on any given day, a staff member, a healthcare provider, is being assaulted. But if you look closely at these headlines that you see here, these are not always conducted by gang members or meth addicts. Yes, they're concerning populations in their own right, but we're addressing violence from older populations. We're people who have mental health issues. They're visitors of patients who are upset with the care rendered or about the outcome that may have been the result. It's really important that you understand how healthcare violence is impacting. And when we think about traditional workplace violence, this is not the same as what we see across all industries. We're talking about something that's much more specific to the patients and the visitors that come with them. So in saying that, I think it's also important that we think about this from a different perspective. I mean, because so many physicians and nurses have experienced or witnessed violent acts. We're talking biting, scratching, spitting, kicking, punching. We've had some patients who have thrown objects, including chairs. Others have yanked out their IVs and threatened to fling blood at providers. I've known doctors, I've known security officers who've had to change their clothes because the patient might have thrown feces at them and had it on their shirt. And what's sadly is this is not always intentional, but we have seen intentional urination on nurses. We've seen things that folks have been coming out of the emergency room and they're bleeding from their scratches and just basically they're crying because of the so many instances of verbal or emotional abuse. What's important to understand is that, frankly, as you can see by the CEO at Cleveland Clinic, this is something that our care providers are being faced with, not just once in a while, but on a daily basis. And it's what's so sad about happening. So what are we doing to try to combat is really what I want you to hopefully take away from our conversation together today. But before we do that, let's talk a little bit more about why the violence has happened. There are a number of contributing factors. Some of this is related to alcohol and drug abuse, as we would expect. We see so much in a prolonged wait time as it relates to the amount of time people spend in the chairs. And sometimes healthcare hasn't always been in tune to how long that's going on. You're starting to see that change a little bit. And I think you're seeing the amount of violence coming from the waiting area reduce as a result of that. But we also have the uh, behavioral psychiatric treatment centers themselves. The sad news is we're seeing that these facilities have been losing a lot of their beds. I live in Colorado. I have been here since 1994. In the 20 years after I moved here in 94, I've actually seen something and witnessed 60% of all of our psychiatric inpatient beds have been eliminated. They're gone. So what's that meaning? That we're now serving the same population in a different location, the emergency department, oftentimes for their medical issues, not their mental issues. But once they're there for a much longer, prolonged period of time. And that's creating some staffing issues inside of emergency departments. And sad news is we're losing a lot of nurses and care providers just because they don't feel safe at work. And they're wanting to have that sensation that says, wow, I really care so much about the patients that I'm serving, but they actually have to take care of themselves as well. And so that is creating an inherent issue of just understaffing across the entire complexity of healthcare. Then we also have to deal with the stress of the environment itself. And I just think it's important that you realize, and the stress of the environment is really critical. And I think it's understanding that when you think about some of the worst things that happen in the community, where do they go to get assistance? Where do they go to get help? They're going to go inside the emergency department. They're going to go inside of the healthcare facilities themselves. And I think it's important that we all understand that it is not a traditional environment where people really typically want to be. It's usually someone who's there to visit or care for a loved one, or they're seeking services for themselves. Sometimes it's with planned, other times it's an emergent situation and things are happening at lightning speed. And the stress that accompanies that with everyone involved is just immense. And I think as we think about what I said earlier, our utilization of the emergency department, not only have we seen the mental health facilities reduce, but in almost that same time frame, we've seen a 50% increase in all of our utilization of the emergency department. So the emergency department is a major location of where care starts. And it's important for us to know that because about 50% of all hospital admissions start from the emergency department themselves. And we don't really quite know who we're seeing until they're there. So that brings us up to some other points. So let's dig into this data a little bit further because we talked about nurses and doctors getting hit, but look at these numbers. These stats right here are absolutely amazing. Nearly 50% of all emergency physicians say they've been assaulted. Can you imagine that? Every doc that you know, 1 in 2 have been assaulted on the job. There's not too many professions that are going to have that kind of ratio. But when you start looking at the actual emergency nurses reporting being hit or kicked on the job, it's even higher at 70%. And that's not even including all the verbal, emotional turmoil that's being placed as they're being looked on. But when we start thinking about, well, what can't be done? Well, let's also think about the cost associated with this because as a CEO that I've worked with in my past, Wayne Shell, he's always shared something with me. Form follows finance. And when we start thinking about that, we have to remember that the cost of violence inside of healthcare, this was a report in 2017, looking back at the year of 16, but 2.7 billion is the economic impact of violence inside of healthcare alone. And it is something that is not small. That's a very material amount. And we're starting to see that healthcare is starting to pay attention to this because they're not wanting to be tolerant. They're not wanting to just expose their doctors and nurses. But this is not like violence that happens on the street or in other entities. This is an area where, because it may not be intentional or it may be driven by a medical diagnosis, that we have to have a different understanding and empathy towards the issue. So What's the industry actually doing to combat violence? Well, I think it's important that you understand an organization that I have mentioned earlier in my introduction, and that's the International Association for Healthcare Security and Safety. They've provided guidance addressing workplace violence issues really since their inception, which was in the late 60s, but has been doing so with a greater sense of urgency and in collaboration with other trade associations involved with healthcare since 2016. They've been development of guidelines specific to workplace violence that's been involved with input from the Association of Nursing Leaders. It's with the American Society of Healthcare Engineering, as well as the Emergency Nurses Association and the American College of Emergency Physicians, among others. This input has included the determination of the type of guidance that's needed, the review of draft guidelines that have been crafted, as well as getting their recommendations for the edits and frankly, reaching consensus on what we should be doing that's now embedded in the guiding documents that you see that are called the industry guidelines from IHSS for the healthcare security industry. These efforts, these collaborative efforts, are particularly important in guidance for threat management, patient-on-patient visitor violence, as well as the design of the space to mitigate violence. I think it's important that you realize that the IHSS is a great repository. If you're serving the healthcare industry, if you're working inside of healthcare as a practitioner, you should make certain that you're staying compliant, but also using this approach that the guidelines are providing. At the end of the year, you'll see an actual bundle of workplace violence guidelines that will be available from the association just to address the continuing growth of workplace violence inside of healthcare. But in addition to that, you're going to also see that the foundation that is the supporting arm, the philanthropic arm of IHSS, is also putting out a tremendous amount of information. They call it their evidence-based healthcare security research series. You could see on the screen that the white paper that was crafted is on reducing violence towards healthcare workers. This is also the organization that produces the annual crime survey for healthcare facilities, which becomes a very important understanding of what the issue is driven when it comes to the industry, not just your location or not to any one individual health system or site of care. And I think it's important, though, that we spend most of our time together today on something that's been really near and dear to my heart, and that's the security design guidelines for healthcare facilities. These security design guidelines were first introduced in 2012. It's a multidisciplinary group who brought these together. There were people like myself that sort of relate as security practitioners, but we also had folks that were experts in CPTED, people who understood the regulatory environment and understand the facilities and the commissioning issues that go along with new construction and renovation. But it was really to provide a very prescriptive approach to how do we build security and the concepts of layers of protection inside every new renovation and each new construction project. So these guidelines, unlike the industry guidelines, who are written for the practitioners, these are actually written for them, plus design engineers and the architects that are out there, project planners and building owner representatives, as well as key department stakeholders. It becomes a checklist of sort that allows you to understand what should we be thinking about as best practice that's included inside of our design, which is something that's very important. If you're an installer and you're trying to integrate some of your systems, you really want to understand what are the best thinking towards where do we put our cameras? How do we manage access control? And what are those things look like? But let's talk about access control, because there's layers of protection that are so deeply embedded inside of healthcare, I think are going to be found in this slide here. And this is a slide that really thinks about this conceptually. There is the property perimeter. You'll notice that some places that you'll go to actually have security officers and gates and items that will allow people in all the way out to the external perimeter. But for other organizations, that external perimeter is maybe only defined by a natural barrier, a sidewalk, or some other man-made approach. It's typically going to be based on the assessed risk. But then we start getting into the building perimeter, where we start looking at how do we allow ourselves to get people in and out. This is where we start chatting a lot about how are we actually defining our doors that allow entry. What are the doors that we really want to have our patients and visitors enter into, not only for good security, but for a fantastic patient experience as well, which we always want to make certain we're connecting those dots to. But that patient experience is also a place where people can help them with wayfinding and guidance and help them navigate the maze that it typically is most every healthcare facility that you walk into. Beyond that, we start getting into, well, how are we segregating these folks that are coming in? Because the interior perimeters have areas that will segregate the visitors, and we need to be certain that we understand how the flows in and out. You may remember, for those of you who ever studied Disney concepts, there is what is on stage, and then there's what's off stage. A lot of the on stage is aesthetically pleasing. What's off stage is where we as workers are at, but we are not really wanting to have patients and visitors and those who haven't been vetted or have the necessary credentials to be able to get into these locations, because not only is it not the right experience, but this is part of our security plan and our security approach. Then we start getting into the areas of, okay, well, what are the places that we're defining as different for public versus staff areas? Sometimes we will want to have the public in a department. They'll be vetted and allowed, but we're not going to want them in certain areas within the department. And then we're going to have that last area, which are these areas that are very highly sensitive. Obviously, we're going to have very restricted controls any place that's housing our drugs and our narcotics. We're going to any place that's going to be housing our infrastructure, our telecom rooms, areas that we know that could actually really cause great damage, not only to the physical plant, but possibly to the reputation of this organization. So we wanted to make certain as we presented this concept of CPTED inside of healthcare that we actually had a framework that we're using. And that's really what leads us into the next thing. These basic tenets that are embedded inside the IAHSS guidelines for the security design of these healthcare facilities. Number one, they're applicable to all healthcare facilities. And what I mean that is there's hospitals, and then there's other locations of care that are not the hospital proper. You probably have seen in your community the freestanding emergency department that 5-10 years ago, you probably thought was the weirdest thing you've ever seen. Now it's become part of our everyday expectation for where care could be rendered. These are also applicable to those standalone emergency departments. You may see an ambulatory surgical center. You'll even see that we've written in this new edition that was just released in June of 2020, a new chapter on residential long-term care for those that have a very specific need where not only are they patients, but they're actually residents, and they will have varying levels of security concerns. May not be the same as you might see inside of an emergency department, but they could create some issues, especially with wandering and other issues where the mental capacity may not be exactly what you would see with some. I suggest this understanding because what this really puts an onus on is the importance of the involvement of the security practitioner in the security leadership or someone with healthcare security knowledge to early on in the process conduct a security vulnerability assessment. This should provide a lot of guidance, and where the design guidelines become phenomenally involved with helping steer the thinking. Again, a checklist approach. Have we considered, have we thought about all the issues that should be out there? It really is about what should be done. It's not a lot. It's not really what I would refer to as an educational document about how and why, but what should be done. And I think that's important because what we try to put in our attention is what should be clear and concise information written in a manner that is applicable to all. But we really wanted to make certain it could stand up to the test of reasonableness. If we were to ever find ourselves, did we have the proper and appropriate level of security in place? If we follow the guidance in the document itself, would it stand up to that test of reasonable? And we believe it does. And there's a lot of subject matter experts and a lot of folks who have been sworn in and in court, basically recognized as experts in this field. And I think that's what really helps everyone understand that, hey, if we're following these guiding principles, you're going to find yourself in a smart, protected place. not only from the built environment, but from the scrutiny that's going to come from when an adverse event does happen. Were you taking all the necessary, reasonable, and appropriate precautions while maintaining cost effectiveness? Expense avoidance, in my opinion, in doing this type of approach in the planning stages early is such a, we're confident it's a 30% saving in the operational expense when you're applying these type of principles inside of this. And for those of you who love emergency management, emergency preparedness, there's even a section inside of here that is focused on it. Most of these guiding principles are all security with very strong emphasis on security. But because emergency preparedness and security are so closely connected in so many different ways, we did make certain we wrote a chapter that was really talking about the implications of those efforts and how we make certain that we are connected to the best thinking in the emergency management arena. With that being the case, let's maybe do a deeper dive inside the emergency department. I've already described to you it's a point of entry inside of healthcare. It is an area that is really it's a portal of entry that you just are not certain who you're going to see. So you think about it, when somebody walks into the emergency department, oftentimes the first person they're going to see may be a security officer, and the second person is a triage and a nurse who's going to actually assess their issues, their medical issues. Maybe find out if there's a history on this individual in the back end of the electronic health record. But what's important for us to really think about is inside the emergency department, the control of access to the greatest degree we can possibly get, segmenting the difference between the waiting area and where the medical treatment care is actually delivered, and having methodologies and mechanisms to make sure that's controlled. But when you think about the waiting area, which is a very strong area for violence to occur, how do we control the furniture that's in there? Are those pieces affixed to each other, the floor or the wall, so they can't be picked up and used as a weapon? We try to help people understand they need to avoid small, singular pieces if altogether possible. Our wall hangings, our code hooks, other hung objects shouldn't be positioned to present a safety risk to the average sized person. So they got to be positioned at a height that not only to put ourselves in a place where we can maintain a clear sight path, but we don't want it to be something that would protrude into the corridor itself. And I think it's important. We also have some areas where if we have everyone else in the medical treatment area cordoned off, we find ourselves in a place where from time to time, we have people who are public facing, who are in what we refer to in healthcare as the chairs or the waiting area, whether it's a triage nurse or a registration admitting folks that are really a part of just that environment. But they look at you and say, well, what about me? What are we doing to control and protect my interests? Because I'm actually here where some of the more concerning behaviors might be, or before we actually know how concerned we should be with any individual or individual's family. But these work areas we want to look at, and you can see on the screen, we're trying to create unwanted access. So those designs, although they need to be ADA compliant, we want to make certain that they're of sufficient height, strength, and to make it hard and difficult for someone to ever jump over. Almost curate a barrier, mind you, to make certain that they can't just pop over and assault an employee. That degree of enclosure is always going to depend on that security vulnerability assessment. You'll see some that will be very restricted and others that will be open. The best practice is really understanding the concern and the assessed environment. But these workstations should be positioned to provide a direct access to an exit portal, a safe drop back zone, and equipped with strategically located duress alarms. When you think about these individuals will need to summon assistance quicker than most because they're going to be right there interfacing and interacting with a lot of people. And we're not going to know who those individuals are sometimes in the earliest stages of their time once they present to the organization. But that designated safe room, we want to make certain it's established so it can be locked from the inside. We want to make certain that it's a place that patients, visitors, and the staff can retreat in the event of immediate threat of danger. But we also want that safe room to be equipped with a duress alarm, a telephone, reinforced doors with a peephole installed, or some other maybe video surveillance that would allow them to see what's happening outside, as well as external lock and key access. But what you're seeing here is a concept that is saying, what can we do with the built environment, not just utilizing physical security people to protect them, important as they are, and they're always going to be the heart of any security program, but there are a lot of things that we can do beyond that. And the next piece really speaks to that. You'll notice in many emergency departments, there are actually rooms that are being designed now for high-risk patient observation. High-risk patient in this regard means that there's security risk. Could be a threat to themselves. It could be a threat to others. It could be a threat to leave because they are on, it may vary based on the state, what it's called. In Colorado, we call it a mental health hold. It's called a Baker Act in Florida, 5150 in California, and most every state has a unique sort of nomenclature name convention to how we refer to these particular individuals, because that means they're on a hold, and that means that the organization has responsibility for their care and they can't leave just because they may want to. So that's basically referred to as an elopement, which is very different than leaving against medical advice. But in these elopement circumstances, those are things that we have to take precautionary measures as well. But for the vast preponderance, when you look at what you see on the screen right now, there are ways that we can actually create rooms that could actually have multiple uses. Some organizations don't see tremendous amount of high-risk patients, and it's hard to cost justify designating a room that is sterile from a weapons perspective and all items, where others may see that they need 6 of those. But in some situations where we want to see these rooms be used for multiple purposes, you could see this on the right-hand side that we actually have an area here that is focused in on a very traditional room, but you can actually see this almost garage door style approach that is allowing us to secure this room completely different than we would have otherwise. And now you can see how that modified room, how that environment has been changed as a result of knowing that our patient population, the risk presented by the patient, has changed the environment itself. So these are some important items that we do that are really in the built environment, and they become protocol based once we have this established. There are other things that we can do as well to create rooms, and in the 2020 design guidelines, the 3rd edition that were just released, we actually spent a lot of time talking about a suite of rooms that might be used. But I wanted to make certain that you could all understand how the built environment and these principles can really do a lot to mitigate the violence and combat it itself. So as we go through it, though, let's maybe switch our gears just a little bit and think about what's the standard hospital room. This could actually be an emergency room, but let's just take a peek at a few things here, because what you can see inside of healthcare, especially for those who are concerned to themselves, the risk of suicide is huge inside of healthcare. Sometimes we have very clear understanding based on the diagnosis and the assessments made by our care providers of what the risks are. Sometimes we don't, but when we know it, there are things that we are expected to do by our accreditation and our regulatory bodies to prevent suicide risk. And the issue is called ligature risk. And what we're trying to do is basically minimize those risks. And in some situations, we're obligated to do that, especially when we know we have someone who is having self-ideation, suicidal ideations related to that. And that's not uncommon inside of healthcare. It's not something that's spoken about. It's not written about with tremendous amounts of volume. And if you're not inside of healthcare, it's probably not as obvious. But I'm sure as you're hearing me use these words, you're thinking, oh, wow, I guess that makes sense. Some folks are needing the care. Other folks go to the healthcare facility just because they think that's the best place for them to actually fulfill that last wish and that last effort before. But you'll notice that the risks that we're facing, look at the curtains and the window coverings. Those are considered ligature risks. We have to be mindful that somebody could actually use them to hang themselves. You can also see that the light fixture could be a ligature risk, something that could be hung from. And so we have to be very mindful of that. You could see that the medical equipment could be a ligature risk. It could also be a weapon risk. So when we start thinking about sterilizing a room from weapons, that's what those other garage doors were really helping us achieve. You can see that the telephone that might be in the room. So these are things that could be a risk from a literature perspective, as well as a potential weapon. Then you could see the chair that's in the room. You can also see the furniture that's in the room. The bed could have multiple ligature points, cords, linens that are on it. So these are all things that have to be taken into consideration. Some of these are in the built environment. Others are part of the protocols and procedures that are utilized for how we protect our patients. But the environment that we create when we know we have individuals who present this type of risk factor to us, we have expectations to take. This is where, when people who are serving the organization and are serving these particular patient needs, we want to make certain that we actually have them a means to communicate, to give them the capability to summon assistance. They may need it where it's isolated and they're actually wearing this device so they can get summoned help. As you know, I mean, we're being hosted by Innovonics. They have a phenomenal product to allow us to do that. And I encourage you to give that some consideration for those that are really taking advantage and serving this particular patient population. And let me offer, those who present suicidal risk, they're not always in a behavioral health unit. General med surg is one of the single most common places for workplace assaults to happen in healthcare. It's only behind the emergency department. It actually is more common to have happen in general med surg than it is a behavioral health unit on average. That's something why we have to provide some of the mitigations that we're doing across the entire spectrum. But if I transition us back into the environment itself and just start contemplating, hey, what are some of the things that we can do with the built environment? The real deterrents as well as the psychological deterrents. For those of you who are really trying to help healthcare understand how to leverage technology to its best advantage, or you're part of the built environment and you're trying to design something that really makes it a safer environment, there's metal screening, which I absolutely do believe is a strong mitigation to violence, where the amount of items, prohibited items, I'm not even talking about TSA related prohibited items, I'm referring to true weapons, knives, nunchucks, ice picks, guns. It's amazing the volume of weapons that is taken off of patients and visitors. Dare I mention staff members from time to time, but mostly patients and visitors when they're coming in. It's in our community, and of course it's coming in. So we want to have a process where we know how we're doing that. But the assessment of metal screening in the renovation of an emergency department or in the new design of a new emergency department, it should be given due consideration. And what does that mean? We have to have space considerations. We have to have queuing capabilities. We have to have storage for items that will be found. It is a very hard retroactive fitting process. Organizations I've known have done it, have spent a tremendous amount, but for those who've done it on the front end of this, even when they didn't know they wanted to have it in the beginning, but they knew the lifespan of this project was going to be 10 to 15 years, I am encouraging that they at least design, where would it go? How would we modify the environment to incorporate it so that we can make a much easier transition if the protocols and the process is something that we agree to. If we don't make that simple design plan, then the event that could happen that says this is what we're going to do, not only is it going to be very detrimental that the event happened, but we might find ourselves doing $1 million retrofit just to incorporate metal screening. And sadly, I've seen that happen in organizations that have had those adverse events. But I think it's also important that you look at other things. If you've known me and have heard me chat in the past, you've heard me talk a lot about signage. I'm not a huge fan of a lot of signage. Sometimes we have to do it because of local municipality rules. The authority having jurisdiction may say we can't prohibit weapons if we don't put signs up. But when I start thinking about signs for video surveillance, what I do know is that when we actually show a monitor at the point of entry to the emergency department or other places or in a waiting room and let people see that there is actually video surveillance, we're actually getting into the psyche of the person that says, you know what, security is taken with great seriousness here. They're using video surveillance. my actions are seen. It's a different way of using greetings to acknowledge that people are there, and people will look at themselves on video. It's been proven. They may not read the sign, but they will look up and see, and they may be fixing their hair, doing something else, and just realizing, but in their psyche, they'll realize it. And that's a strong deterrence. So let me sort of wrap this conversation up with a really simple slide. When we're trying to manage violence in healthcare, which is the largest and most pressing risk facing healthcare, 80%, if not more, of all of our events that we deal with in healthcare are basically workplace assaults, mostly patient-generated violence or that committed by their visitors. We have to have a safe space design. That is absolutely critical. From there, our teams, our folks, our colleagues, they have to be prepared to manage that difficult individual. That happens with training. It happens with smart protocols. It happens based on some of the guiding principles. And I encourage everyone to pay attention to the industry guidance that has been produced by IAHSS. It's been very thoughtfully produced. And then there's this whole mindset that says sometimes we can't de-escalate. Sometimes we actually have to get into a mode where, you know what, if we aren't getting hands-on, people are going to get hurt, and safe patient care is not going to be delivered. And they have to have the mechanisms to be able to do that. It's always going to be a means of last resort, and no one wants to ever do that. But there are times when it has to be done. But design this space smartly, safely, provide the right training, and then be prepared when the inevitable issues happen, that we have to get to a position where we're going to have someone who's going to be big or small, young or old. And, you know, there is no profile for the person who commits an act of violence other than the fact that it happens inside of healthcare. With that, I hope I've given you a nice little bit of understanding associated with a safe hospital design. It's a phenomenal topic. It's one that we're trying to educate a lot of architects and a lot of building planners, a lot of facility engineers, as well as those of you who are on the provider side of integrating a lot of this technology inside of healthcare. The principles that are applied, everything I've shared with you, probably found in varying ways inside of our design guidelines for healthcare facilities, inside of our industry guidelines, or some materials that I've written with some great colleagues, Russ Colling, who was the original author of Hospital Security, and my most recent co-author, Don McAllister, who has been heavily engaged and helped me understand the international community better than I ever did. But with that being said, I'm always open to a conversation. If you want to pontificate or just discuss my favorite topic of healthcare security, please reach out to me at tyork@paladinsecurity.com. or shoot me a text at the number provided, and I'd be happy to help you or assist you in any way I can. I'm on LinkedIn. I tweet a little bit, not nearly as much as others, but from time to time, if you follow me, I think you'll find that there would be some pretty good information that you'll learn, you'll share, and stay current on some really credible issues that are facing the industry. With that, I'll just share there's a few references, some resources that I just want to make certain you knew how to access some of the materials I've changed. I really appreciate you spending the time with me. Thank you, Innovonics, for the opportunity. I think you guys have a tremendous product, and I'm really excited to see and continue to see the innovation that you're providing in this whole space of really helping with a great need of communication, especially in emergent needs. Thank you. Take care.